pain. The second thing you have to avoid is so-called siloed spine care. Most countries in the world, you have tertiary hospital care and universities where all the surgeons and medical specialists are and the high-powered equipment. You have district hospitals and clinics where you have family physician and nurse practitioners. You have private practices where most of the chiropractors and physical therapists and occupational therapists work. And then you have the villages, which is the majority of the population, which is basically the treatments maintained by traditional healers, police, first responders, and community health workers. These are multiple different professions who have different training, different terminology and language. Often non-evidence-based interventions have been prominent in their curricula. There's been no communication between them and no real coordination. The third point is that you have to avoid unlimited and indiscriminate increase in spending on spine care. This study by Dieleman in JAMA estimated that in 2005, $87 billion has been spent on the management of back and neck pain. And that had increased by 57%, 57 billion since 1996. But that didn't stop there. A recent study showed that in 2016, low back and neck pain had the highest amount of healthcare spending among 154 different conditions, with an estimated spending of $134 billion. Now, this does not count the disability, the impact of society. We did a study which showed that disability probably adds another 4 times as much disability cost to society. So we're talking $500 billion in the United States is what low back and neck pain is costing society. And if we look at the data, it's almost all the high quality, the high cost care, imaging and expensive testing, opioid and other prescription medications, epidural steroids and other forms of injection, fusion and surgery, all have shown this exponential increase in the number, in the cost and the number of procedures which occurred during the period. Deo and Martin published a paper which showed that during a period of time when total expenditures increased by 60%, the amount of functional disability and limitations due to back and neck pain increased by from 20 to 25%. We're talking about if you throw money at it indiscriminately, the increased expenditure actually increases the amount of disability. So what we've managed to do in most of the Western world and the high-income countries is focus on the tertiary care, the highest quality care, and ignore the primary spine care and the low-income and the prevention, which is where the majority of the population should be treated. We've been giving the wrong care to the wrong person at the wrong place at the wrong time. So what does World Spine Care bring and the Global Spine Care Initiative have to do with to offer Nepal in this venture? World Spine Care is a nonprofit charity registered in the United States, Canada, and the United Kingdom with the goal of helping people with spinal disorders in underserved communities throughout the world. You'll hear more about it from other speakers. But basically, it's offered. We have open clinics in Botswana, India, Dominican Republic, and Ghana. We've had educational courses and conferences in Botswana, India, Nepal, and other places. And we've done a series of research studies, including the Global Spine Care Initiative and guidelines, and you'll hear about the implementation and outcome study. The Global Spine Care Initiative was an initiative that was put together with a multidisciplinary task force of 68 spine care clinicians and researchers from 22 countries. It was for development and evaluation of innovative integrative model of care to improve the management of spinal disorders, with the goal of reducing the associated global disability and burden of disease. 15 papers were published in the European Spine Journal in 2018, which outlines the details of this study. Basically, it comes down to the following. There are three major components of society of spine care. The first is community-based programs. The second is primary spine care. And the third is secondary and tertiary spine care. This is where the main hospitals and so on are. This is where first triage and non-surgical interventions are given, as well as the diagnostic decisions. And the community-based is where education and monitoring and sorting people out for those who require care and those who do not. We're talking about working with a primary care provider team with a close integration with secondary and tertiary spine care and self-care and community practice as a well-oiled machine interacting with each other in a consistent fashion. We're talking about the majority of people in the community having access to self-care and community programs. Those who require triage and some form of treatment have access immediately to a primary care contact spine care clinician. Some of them require secondary care at district hospitals with some basic testing, and a few are sent to those tertiary spine care centers, which require the high-powered surgery and specialist care. If this is done correctly, these people will only see those patients who require their level of care. This is the right care, the right person, right place at the right time. It's a patient-oriented program. Social work and community program, service workers or first responders, unlicensed healers or self-care, licensed healthcare practitioners in primary contact, community hospitals and community emergency rooms, and tertiary hospitals and multidisciplinary interventions. It's coordinated care between these groups with triage to ensure that patients end up in the correct category, as noted below, and you'll hear more about, coordinated evidence-based spine interventions, and integrated primary contact people with a great deal of education and collaboration. In conclusion, you're going to hear a lot in this symposium about this model of care and the problems associated with spinal disorders and how they could be alleviated. You're going to hear about what's happening in the rest of the world to try and deal with this problem. And I hope you find it useful. The conclusion is it is possible to improve the quality of life and reduce disability resulting from spinal disorders with an evidence-based, patient-honoring model of spine care.
Thank you, Professor
I want to thank
Scott.
you all, and I look forward to and hope you will enjoy listening to the other speakers in this symposium. I'll be available to answer questions and direct questions at the end of the symposium.
Professor,
Good afternoon.
thank you, Professor. We will take the questions at the end. Now we'd like to invite our next speaker, who is going to be connected with us virtually, Deborah Kopensky. She's going to talk on global burden of disability and its impact in Nepal. Is she connected? Oh, she's not online. Shall you go ahead with the next speaker? Yeah. So how is treatment of spine pain delivered in Nepal currently? Dr. Bimal Pandey, he's going to talk on that topic.
Good afternoon, everyone. I'm very pleased to be here. I feel honored by Nissan and everyone here. And thanks a lot for inviting me to speak few words about the spine care and spine pain management in our country, how it's been carried out. Slides. Yeah. To start, how is the treatment of spine pain delivered in Nepal currently? Spine pain, this is one of the most common cause of disability in developing world. So in our country, if we go to the rural area, even more spinal problems are there, which has to be tackled carefully and which hasn't been dealt till now. But in urban areas, some of the spine pain has been managed pretty well, but we have to do a lot, especially in rural areas. And different modalities of treatments are there. Physical treatments, rest, exercise, physical modalities, usually it's been done by physiotherapists. And gradually this modality of treatment has been promising and getting advanced in our country as well, but still it's in the urban areas, not outside the Kathmandu Valley or in rural areas. Another modality of treatment is medical treatment with the help of medicines and some neurosurgical interventions or non-neurosurgical interventions. These are generally done by the pain physicians. There are some group of people, actually they're from anesthesiologists, and for the last few years they have been coming up with different type of pain identification. They are trying to find out the pain generators, and non-surgically they are trying to get relief of this pain and helping out of the people. And another is surgical treatment done by spine surgeons. And treatment is carried out by different professions. All these three different type of treatments have been it has been carried out in our country by different type of peoples with different modality, different educational group or different type of traditional group as well. And our government hospitals are there all over the country. Regional hospital, there are 6 regional hospitals in our country from east to west. And these regional hospitals are well equipped with the facilities to take care of a spine, starting from physical therapy, some medicine, a little bit of intervention by anesthesiologists, and other surgeries are also in some of the hospitals. And other general hospitals, 11 general hospitals are there all over the country, and they are also a little bit advanced in terms of taking care of the spine pain patients. And central hospital, 11, and these central hospitals are located mostly in bigger cities, mostly in Kathmandu and bigger cities, and mostly the people from outside the valley and rural area are facing difficulties to get the treatment, simple treatment for spinal care, spine pain in the centers like those. And there are government teaching hospitals, 5, and there are 15 private medical colleges giving services to the spine patients. District hospitals, 56. In district hospitals, though there is very less facilities of other specialties rather than physician and clinicians. Physiotherapy and other modalities of treatment are not in that advanced stage in those hospitals. And the investigating tools are also not easily available in those hospitals. The plain X-ray is the most that people can get in those hospitals. There's no questions about CT scan, MRI, nerve conduction test, and others. And 15 bedded hospitals are there. There are 13, and these are very small, run by few doctors, few physicians, even not specialized doctors. and they are taking care of spine patients over there. But besides spine care, they have to take all the patients, from patients of general surgery, chest infection, or urinary tract infection, whatever. They are taking care of all the sorts of patients, and they are not well versed with the spinal problems. And if you go to the website of Ministry of Health and pick this, and what's about the private institutions? Those were the government institutions. And what are the facilities that have been provided by the private hospital? If you go to that column, you'll see list of private institutions. And starting from the one, if you scroll it, you'll be tired of scrolling this. Altogether, there are 962 different institutions, private institutions, only in Kathmandu Valley. Out of those, more than 50% are clinics, polyclinics. Few, and 1/3 of those are dental clinics, and few laboratories. But more than 50% are the clinics, private clinics, only in Kathmandu Valley. These sort of different type of, and can you imagine, do we have that manpower in Kathmandu Valley? Obviously, no. We can imagine how these have been giving the services to the spine care patients. And beside those, we have other facilities, other team of the people who are taking care of a spine problem in Nepal. Unani hospitals, Ayurvedic hospitals, homeopathic centers, they have their own protocols of treating. They have own diagnostic tools, which doesn't correlate with our modern or with our allopathic medicines. But some of the Ayurvedic hospitals are now, they are trying to read X-rays, they are trying to do some ultrasound to diagnose some of the diseases, and even they are doing a little bit of hematological blood investigations nowadays. Otherwise, homeopathy center and Unani hospitals are not, they have their own ideas of or definition of the spine pain, but they are giving services to our people. And the difference between Unani and Ayurveda, a little bit of difference there. And another one is nature care hospital. Nature care therapies are there. In our country, we don't have any institution that gives proper training of, or the proper educational training to those people. And nobody knows where they come from, but there are few centers and they are running and they are taking care of good amount of people in our country by themselves, and Ayurvedic clinics are there. And going through, there are lots of advertisement, or they have very good websites in the internet. You can go there. And one of the Ayurvedic hospital there, and they are doing a little bit of some kind of surgeries as well. And if you carefully see how they are equipped in the operation theater, look at how they are wearing their masks. And some people are wearing masks, but without coverage, head cover. Some of them are using head covers, but with no mask. This is the scenario. This is also one of the institutions where spine care is being taken place in our country. There's a manual therapy. And till date, I don't know, there are not much of the chiropractor or well-educated chiropractor in our Nepal. But still, there are a few centers who claim that they have chiropractic facility over there, and they are doing some manual therapies, but they are not having a good degree of their professions, but still they are treating our patients. That means our population is getting treatment over there. And investigation, what are the investigations that we are doing to get to further treatment of spine pain patients in our country? X-rays and other hematological investigations, ultrasound, CT scan, MRI, nerve conduction test. And if there's any pathology in spine, aspiration, cytology, microbiological tests are there. and even a biopsy. But how many of the care provider are well versed with these type of investigations? Usually physicians and surgeons and now the physiotherapists, they can read the x-rays and they have they look for the MRI findings and they correlate clinical treat their clinical disease with the radiological finding. Even some hematological tests are being done, but most of the spine care providers that I listed above are not versed, are not well trained how to interpret these investigations. But without correct investigation or evidence, people are being treated by themselves. And physicians and surgeons, Association of Spine Surgeons of Nepal and NASON, this is spine chapter of NASON, and anesthesiologists who have their own, this Nepal Association for the Study of Pain, they come out with evidence-based practice and they're doing the right judgment. But the number of the people giving care is very less spine surgeons and physicians are there in our country, even physiotherapists. And another group of people are there. There is a pain surgeons, pain physician, physiotherapy are there, natural therapy, Ayurvedic medicine, others. But what I do is only the treatment of spine pain. Everyone thinks that what is doing is the right, and that is the way how to treat the spine care. This is wrong. There's no correlation in between or connection in between those specialties. The person who has gone to one specialty, one center, will be held till the end. That is the thing that we have to correct, and we have to correlate. And a lot of times, spine surgeons are doing surgeries which could be well tackled by plain physician or by physiotherapy. Overuse or over indication of the spine surgeries is being done. In reverse way, some of the physiotherapists, in that some of the patients with some early developed neurological signs and symptoms are not picked up by the specialties, and they are held with continuous physiotherapy. That means no one is perfect in this group. No one is the Superman in this group. Everyone need to be in touch. And if we are able to make a chain in between, then we'll be able to provide a special spine care to our population. And another one point I want to mention is the pharmacy. This pharmacy, you can see, this is a shop. This is the first caregiver in spine pain in our country. A patient having back pain, first of all, he go to the nearby medical shop, just a 2-stepper, right? Go to the shop and he gets free consultation over there. And on top of that, he gets medicine. And he uses that medicine on and off, and usually they provide painkillers, and patient gets relieved of the pain a couple of times. Again and again, he repeatedly go to the shop and buy. And the shopkeeper, that is the person who refers that patient to the hospital. Now you should go to hospital or physiotherapy. This is that's why the role of the pharmacy is the first step still in our country. So I'd like to conclude that this is the scenario, current spine treatment that is being done in our country. Taking care of spine pain shouldn't be generalized. Teamwork always gives a better outcome. Referrals and interspecialty consultation is advisable. We should develop common language between all the stakeholders taking care of spine pain, and should understand one's limitation. We should understand our limitations. Thank you very much.
Thank you very much, Dr. Bimal Pandey. He is the president of Association of Spine Surgeons of Nepal, and he worked a lot for this presentation, it seems. The next presenter is Dr. Jeff Outerbridge. he is the clinical director of World Spine Care, and he will be talking about what is the Global Spine Care Initiative and how it can help. Dr. Jeff Outerbridge.
Thanks for the introduction. The timing of this is kind of good because the last two presentations have talked about what are the problems with spine care, and not just in Nepal, this is around the world. And what I hope to offer today is a little bit of a glimpse of how we might solve some of these problems. When we first started, Dr. Haldeman talked about the model of care, the Global Spine Care Initiative, how things have to integrate. And you can take an ideal model like that, but when you try to apply it to a particular place, you realize that modifications have to happen. And so what I'm going to go through are some modifications for those people who've seen the presentation, the workshop we did on the Global Spine Care Initiative. You're already going to start to see some changes. Dr. Boussier and I just spent a week out in Gutshore with Dr. Kadka in the frontline healthcare clinics with patients at the Carnally Academy of Health Sciences, gathering a lot of information and coming up with some ways that we can actually make this a little more relevant to Nepal. So I'm going to try to bring you through that. And along the way, I've also added some of the photos that I took while we were on back there. So hope you enjoy those. Okay. So to address this burden of spinal disorders, the Global Spine Care Initiative was developed as a model for prevention and care for people who have spinal disorders. And this was a model that could reasonably be instituted in communities with different levels of resources, all the way from remote, all the way through to tertiary care. So Scott already reviewed this, the Global Spine Care Initiative, multidisciplinary task force, innovative integrated model, and it was published with 15 papers in the European Spine Journal, so I won't go through that again. Kind of stole my thunder. So when we talk about level of spine care within a country, the very first level of spine care is at the community level. That's where most people are going to be entering the system. And in that location, there's a lot that can be done in prevention and community education. But when somebody actually starts to have pain, then they're going to need to see somebody who has some specialization in spine. And we were calling this the primary spine provider, primary spine practitioner. And the concept of primary became a real stumbling word along the way because everybody was saying, well, we should be primary, we should be primary. Well, the primary contact could be many people throughout the system in Nepal. So instead of talking about primary contact, which everybody can be, we're going to talk about the non-surgical spine care. And then there's a secondary care. And as you go up the levels of spine care, the cost of the interventions become larger and larger. So at that community spine level, this is the health and prevention, physical activity, education about smoking or drugs or osteoporosis and other risk factors. And that can all happen at the community spine care level. When a patient actually presents with pain, then they need to actually see somebody or any spinal symptoms. Now, they're mainly going to be managed by the non-surgical spine care specialists. They're the ones that have the expertise in education, exercise, manual therapy. When it comes to patients presenting with neurological disorders or deformity, some of those neurological disorders can be managed in non-surgical spine care. Some need to go to secondary or tertiary care, and it's the same with deformity. A stable scoliosis with mechanical back pain can be managed by a non-surgical spine care provider, whereas a progressing scoliosis needs to be seen in tertiary care, potentially for bracing or surgery. So they can go either way. And usually red flags are going to be seen at that tertiary care level. And in terms of what proportion of the population really need to be seen within these different levels, the majority of people who are suffering from some are actually not going to have pain, majority, and no risk factors, but it's important to educate in advance. Or they may have some risk factors for developing spine pain, and the prevention and education programs become very important. But then when patients actually start to have symptoms, 90% of those are going to need non-surgical spine care interventions or a non-surgical spine care provider. And then as we go up, some might need secondary care and very few will need tertiary care. Usually around 1% of those presenting with spinal pain actually need surgical interventions. So what the Global Spine Care Initiative is trying to do is trying to get the right care for the right person at the right time, so that anybody presenting with spinal pain, no matter where they enter the system, at the tertiary care level, secondary, the non-surgical level, or the community spine care level, no matter where they enter, people, clinicians at those levels can make the appropriate decision to put them into the appropriate level of care. Okay, and that's kind of what we're trying to do with the Global Spine Care Initiative initially. Get them to the right care and get them to that care as quickly as possible, because the quicker the interventions, the better the outcomes. So if we look at community spine care workers, this is out in the places like Butchor, where we just were, where you have paramedics, nurses, community health workers, and this is where patients are going to present first with spinal pain. And they're going to be primary contact. We want, it's ideal if they have a basic knowledge in spine triage. They can identify red flags and make that decision. And again, when a patient should leave the community and go and have care, or can the patient stay in the community and be managed there. So they'd be trained in spine pain prevention and community education as well. Trained in conservative interventions, including education, maybe some basic exercise prescription, but as time goes by, they can be trained more and more and more. And then safe transport and handling of patients. We've heard a lot of patients who have had spinal fractures and are thrown in a truck and driven for long ways without any spinal stabilization. So that sort of education as well. So that's a community spine care worker. Now, what we just worked out is that red flag screen. And the color coding in here actually matches the different classification system, which you're going to see in a little bit. But these are questions that we try to make very clear and very direct, so that anybody, whether it's a physiotherapist, first person seeing them, or a surgeon, or a medical doctor with no background in spine pain, or a community health worker, a paramedic, they can run through these questions and decide, does this patient really need to go and see a specialist or not? Okay. And all of these, all the way down to number 8, are red flags referral. And then number 9 is one that can be referred for that non-surgical spine care at this point. And we'll elaborate on this a little bit. So the non-surgical spine care clinicians, they're providers. They have specific knowledge and skills in evidence-based spine care, manual therapy, and rehabilitation. So this in Nepal would best be represented by physiotherapists. In other countries where there are chiropractors who are properly trained chiropractors at proper chiropractic institutions, they also have that level of training. So that's who we're really talking about. This can be delivered in any healthcare setting. However, physiotherapists are usually in hospitals, either secondary care or tertiary care hospitals. They're not usually on the front line way out in a remote village. They're going to be integrated into the healthcare delivery within the clinics, hospitals, or ambulatory care facilities. They may act as primary contact, or they may act as a referral. So again, the primary contact may be a surgeon. Surgeon decides through these questions that they're not a surgical case, or their own guidelines, they decide it's not a surgical case. They're referred to the physiotherapist for that non-conservative care. And they actively collaborate. This is the communication that both the last presentations talked about. It's really important for there to be collaboration, and this isn't a siloed care. So the physiotherapists, the non-surgical clinicians are actively collaborating with other healthcare providers. And that may also include OTs, rheumatologists. It's not just surgical, non-surgical. This non-surgical group is a little bit bigger, but the core element of that would be the physiotherapists. And they may also be referring back to community care or surgical care when indicated. So the surgical care, spine care clinicians are going to be the secondary or tertiary care settings, may act as primary contact or referral from other healthcare providers. We've heard from surgeons in certain areas saying, we want to be primary contact. We're okay with that. We've heard from other surgeons saying, I'm so busy, I want somebody else to make a lot of these decisions, so that the only cases that come into me are the ones that probably need surgery. So the surgeons, may or may not need that non-surgical triage person to do the triage for them. These are the surgeons who have specialty training in surgical interventions for spinal disorders. So the orthosurgeons and the neurosurgeons. And again, we're hoping that they actively collaborate with the other health professionals, and they can refer to the non-surgical or community care when appropriate. So the steps of the Global Spine Care Initiative are, first, somebody becomes aware of their pain. Then they go through that initial triage. And once they have gone through the initial triage and questions, they can be classified into the major classifications. Are there minimal or no symptoms? Do they have moderate pain or mild pain? Do they have moderate or severe pain? Neurological symptoms, spinal fracture, deformity, or any serious systemic pathology. And then now comes the provider assessment. So this is where the non-surgical spine care providers, surgeons, medical doctors, all of them can use this provider assessment, because these are healthcare providers that know how to do a proper history, physical examination, diagnostic testing, and ask additional screening questions to then subclassify the patients. And the subclassifications are, if they're class 0 and they have no pain, do they have risk factors for pain? Do we want to educate them, or do they have no risk factors? Class 1 pain, is it acute or chronic? We're going to treat them different. All the physiotherapists here know that we treat acute and chronic pain a little bit differently. Same with moderate or severe pain. If it's acute or chronic, we have different things that we do with them. So, and in neurological, we've got minor, non-progressive neurological symptoms, acute, major, progressive, and then stable neurological. Under fracture and deformity, there's stable asymptomatic or acute and progressive. Under class 5 pathology, is it acute and severe, slow progressive, or a non-spinal referral from non-spinal structures? So each of these then has, after that, then there's a series of flashcards that you use to decide what's an appropriate intervention for that patient, and then monitor outcomes. So with the provider assessment, again, this is going to be performed by the surgical or non-surgical spine care specialists. Spine assessment, history, assessment tools to measure pain severity, disability impairment, psychosocial risk factors, any red flags, spinal, neurological, and general physical examination, and appropriate diagnostic imaging or laboratory testing when appropriate. And then the assessment, the assessments provide the information for that additional triage and to decide what class and subclass that the patient belongs in. So then what happens now is, let's say a patient presents to a physiotherapist, they're going to ask the same questions that they would in the front line. They want to rule out the red flags. But initially now they need to know the subclassifications that they would deal with. And is this a pain, a type of pain that we can manage? And if so, how do we manage it? So even a surgeon can look through this, or a medical doctor, and go, do I refer, or do I refer to surgery or emergency care, or do I send to the non-surgical specialists? So the physios are getting more appropriate referrals directly to them that should go to them. They're knowing when to move up to surgeons for more surgical interventions. The surgeons know when to move down to the non-surgical care. And so everybody has an understanding of where a patient belongs when, and that helps coordinate the care. And then everybody starts talking that common language that was mentioned in the last presentation. So this is, again, decisions. Is it signs or symptoms of serious pathology? Then it's class 5, and there's a decision that goes along with that. So once you've decided the class and subclass, then there's a card, a flashcard for each of the different subclassifications that lists the evidence-based interventions, what we should be doing for that patient who presents with those symptoms. And this is what the neurological flashcard looks like. So it has a subclassification, what are the assessments that should be done, and what are the interventions that are evidence-based. And we have cards for each one of those subclassifications. So the overall benefits of this Global Spine Care Initiative model is that it addresses the whole person, family, community, and biopsychosocial model. It improves the outcome by getting the appropriate timely care. The patient benefits from that clinician communication. It creates a language and confidence between clinicians around spine care. The surgeon saying, well, we think that the physiotherapists sometimes hold on to patients too long. Well, if that Global Spine Care Initiative decision tree is used every time a patient comes in, then if there are emergent symptoms, then they'll be more easily recognized, and there's a better chance that the non-surgical specialist will be referring to surgery at an appropriate time. It also contains costs. There's going to be less imaging, medication, surgery, and minimal treatments at the inappropriate level of service. This is person-centered care. The patient is at the center of the care rather than the actual service. And at the community level, the benefits are appropriate referral. Patient goes when they need to go to the hospital, and they stay in the community when they don't need to go. It minimizes that unnecessary travel. There's education and prevention programs aimed at reducing the burden and preventing spinal disorders. For the non-surgical spine care specialist, it provides evidence-based roadmap for appropriate care for any presenting spine complaint. Okay, and so the actual full package is really of best benefit to the non-surgical spine care specialists. And it gives the provider confidence in their decision-making and confidence in the other providers they need to communicate with in that decision-making. For the surgical specialists, it gives awareness and confidence in the non-surgical services. And the referrals they get are actually more appropriate. They're not seeing patients that they don't really need to, and may relieve the burden on tertiary care, surgeons not seeing those non-surgical patients. So on Sunday, there's a little thing in your schedule that says we'll talk about the Train the Trainer program. That's actually a gathering that we're going to have on Sunday between noon and 4, and we invite anybody to come and participate in a discussion on the Global Spine Care Initiative and its implementation in Nepal. We need your feedback. So far, we've got a lot of feedback. It's been amazing. And we've really modified things, and we think we're getting closer and closer to a model that really will work in Nepal. And anybody who can come and give feedback and ideas to us on Sunday would be great. Thank you.
Thank you, Dr. Jeff. Now we'd like to invite Niva Bajracharya. She's going to talk on primary spine care providers.
Namaste. Thank you very much for inviting me to speak on this topic. I'm Niva Bajracharya, lecturer at KMC Hospital, and I am also working as one of the core team members of World Spine Care Core Team Group. And we are working together to develop a national spine chapter. So you all must be surprised that my topic of today has been a little shuffled and changed and modified. And this is, as Geoff just in a earlier presentation has explained, like how the primary care providers in our context, how the primary care providers are not a certain facility, like people can land up anywhere. So GSCI model, it is a very flexible model. So as they are taking to different countries, they have been modifying as per the convenience of the context of the place where they are going to apply the model. So this is how my topic has been changed, and the primary and classification of the care providers from primary care providers have been changed to healthcare workers, non-surgical spine care providers, and surgical spine care providers. So today I'm going to speak on the role of non-surgical spine care specialist. So why non-surgical spine care specialists are so important? Because as you all, we have come to know that among the 90% of the spine care, spine problem patients that we see in the hospitals or clinics or anywhere, the majority of the patients that come along are the non-surgical spine cases that don't need to undergo surgery. And we being the physiotherapist, we have the major role in being the non-surgical care providers, because as we know, we have the authority, or we have the knowledge of triaging it, and then whether to refer it to these different department or whether to keep it for ourselves for further treatment. And lots of discussions has been coming in, like different faculty not referring patients to other faculties and keeping them to themselves. Like Dr. Bimal also very rightly said, the patient who enters to certain faculty stays there for long. So this module is to enhance the interdisciplinary network and team and discussions and talk about this. So the non-surgical spine providers, they are generally in the clinical settings and all. As Jeff has already said in the previous, why are the non-surgical spine care providers are very important in this field? Because they have why they have such a potential role as a non-surgical spine provider? Because they know to triage between the red flags, they know to see between the yellow flags if they have any biopsychosocial issues, and even if they need to treat or manage it, they give the exercises, they know the manual therapy that we give, and they have different protocols on how to treat different kind of spinal care problems. And even if while treatment, even if the patient has to go under surgery, we come across the progressive symptoms, then we can always refer them to the surgical care providers. And before that, we can always do the pre-surgical conditioning before referring them to surgery. And as we all know, after surgery, they are always mostly coming back for the rehabilitation process, that is post-surgical rehabilitation. And also another important point why this role is very important is non-surgical care providers gets the maximum time to spend with the patient. We all know we don't spend less than at least 25 minutes to 40 minutes, or sometimes even longer than that, while we treat our patients. In the process, we talk to them, we get to know about if they are going through any biopsychosocial issues, then we can refer them to the psychologist. If not, if we are treating and their symptoms are not relieved, but we think that neurologically involvement is not much, and even if any confusion, we can always discuss with the other faculty and team members and refer them. And then during the follow-up visits, we are the one who generally get to see the follow-up of the patients every day after every treatment or whatever consecutive visits. So after every treatment, we get to talk to them about how their treatment goes, whether they have improved or whether they are not getting better or whether they have worsened. And we also can always talk about the psychological issues. Sometimes we all have experienced that most of the patient who has been there for a long time, who comes to visit us during their pain, they mostly become half family to us. They share everything with us regarding their family problems. And that's how we come to know them very closely and refer them if they have any psychological or biopsychosocial problems. Not working. Okay, these are the GSCI steps that Jeff has already described. And here, why I'm taking this slide again is to emphasize what a non-surgical care provider can do in the provider third step, like care providing assessment. And the blue box that you have seen here in class 0 to class 1 and 2, these are the patients that we always deal with. And as you see, all the blue boxes, these are the maximum amount of patient that we come across of these spinal care problems. And the yellow class 3 are the neurological symptoms, classified under neurological symptoms. And we being responsible practitioners, we need to know the very thin line between minor non-progressive neurological symptoms and progressing neurological symptoms that has to be immediately referred to the surgical spine care providers or to other faculty. And the fourth one is the spinal fracture or deformity classification. Here also, if the spine is stable and there are no other with the minimal deformity and can be treated with the exercise, positional correction, stretching or anything, we can keep it to ourselves. But at the moment, we know that there are some unstable symptoms that are coming during our treatment, during the reassessment that we take the next day. As soon as we come across that, we should not hold the patient. This is our responsibility to keep the patient in the right place at the right time. This is why, again, I would like to emphasize why non-surgical healthcare, spine care providers are very important to take up this role. So GSCI STEPS has already classified and made some questions. All these yellow, that number 5, yellow questions are for segregating it to the neurological, if it is a neurological issue. Orange one is for the class 4 with spine fracture and deformity. All the red ones are the red flags that has some pathological issues. The answers that we get would let us decide to see if they have some pathological issues and that we should not be immediately treating them and refer to other faculties. And the 9th one is the pain. Pain is the major thing that we treat, which is involved with the musculoskeletal issues. And that is again divided into mild, moderate, and severe. And there are different steps that, during this provider assessment, what GSCI model also says is this: all the assessment will be also done by a non-surgical care provider as well as the surgical care provider. So even the surgical care provider would know when to not operate and refer it to the non-surgical care providers. This is why all of us who are going through this, who want to be a better spine care provider clinicians, should incorporate in our practice for better results of the patients. So these are again all the classifications and sub-classification. I'll not go into this much. These are the flashcards. This will be discussed more in detail on Sunday workshops, like how after classifying or sub-classifying into different classification, how we can practice it in an evidence-based manner. This will guide us to be more evidence, do more of evidence-based practice. And always, after every treatment, what we always do is look for the outcomes. And if the outcome is all better, we can always reassess and send them back with exercises and modification, postural modification to the community. If they are only somewhat better or not better or getting worse, then we really need to stop. Like, our treatment should not be a dose of medicine that should be taken regularly at the same place, same phase, same time. Our treatment is always customized. We customize the exercise every day or the treatment every day, depending upon the worsening or bettering of these symptoms. And we take every decisions according to being a patient-centric, taking their feedbacks. So if the patients are only getting somewhat better with few sessions that you have done, or not getting better at all, or getting worse, then we need to stop and think if we need to change the mode of our treatment, if we need to do something else, or if we need to, okay, this is not going to help, I should not sustain this patient for long and we should refer it. Maybe there is something other to be ruled out. And also to see if there are any new spine issues that has developed again during the treatment process. So when we go through all this, what we realized is this is not something very new to us. as when I went through GSCI model, or when our friends who has attended the meeting, they have gone through this GSCI model, the guidelines, we have noticed that this is not something very new that we have never done. These are all the things that we have been doing, but with not the specific guidelines. So why GSCI model and National Spine Health Program is important for our country, I feel, is incorporating this in our practice will always make us practice in an evidence-based way, make us practice in a systemized way with the proper guidelines to follow, when to refer and when not to follow, when not to refer, when to treat and when to refer, and to put the right person at the right place. We will be better clinicians, making better decisions following the guidelines. And above all, also during 2077, Nepal government has again incorporated the basic health care package, healthcare service package in Nepal, which maybe in soon, nearly in future, that will be incorporated. And that has updated the list that musculoskeletal pain, disability, geriatrics, its management, management, counseling, proper referral, physiotherapy, and rehabilitation has also been incorporated in the government list. So more of the patients in Nepal, if this rule gets activated, a lot of patients will be getting free treatment in government allocated hospitals. And this is also why I think this is a very good opportunity that Spine Care National Spine Health Program is coming up at the right time, so we can practice it whenever there is wider range of our practice being explored in the country. We give the best service to the patient, being responsible practitioners. So concluding my presentation, I would like to say that interdisciplinary team, collaborating and working as an interdisciplinary team, teaching each other, learning from each other, and discussing will always be a profession, or will always be a practice of a patient-centered practice. And this will definitely help patients of our country and also to uplift all of our professions. Thank you.
Thank you very much, Dr. Niva Vajracharya. She rightly said that collaboration and interdisciplinary approach should be taken for the patient. It's because the treatment should be patient-centered, and national health policy 2078, as she has rightly pointed, that now it is a very comprehensive policy. So if we can collaborate, if our national spine health program can be, it can be in the right place, if we can approach the government for the national spine health program. Okay, in the same vein, Professor Amit Thapa will be talking about the framework for the program, that is National Spine Health Program, if I'm right. So Professor Amit Thapa, who is President of Spine Chapter, current Spine Chapter.
Thank you, Dr. Neelam. Dear chairpersons and friends, well, this topic which I was given regarding talking about what is the general framework of the things which we are planning is basically the work of the whole team. We have been discussing over the past few months, and then we have come up a long way ahead. So I was just sitting and thinking what we have achieved over the last 7 months. And then we realized that the group, the 68 researchers from all over the world, they took 6 years to draft out this global spine care initiative. And here we are only 7 months down the line, and we have something coming up on our platform. So may I have my slides, please, Junaid? Okay. No, this was my first presentation. Can you put me the second presentation here? So, this was the talk which we had presented on November 27, 2021. So there were a lot of things which were discussed. We have actually come a long way ahead. And now we are talking about what framework could be feasible. So there were a lot of field visits and a lot of things which we have discussed over the period. So this meeting, which occurred in November 25, we had collected there. This was in Yak in Yeti, and then followed in which we had introductory workshop in March 7 and 8, which was participated online. And then we have discussion with Department of Health Services, security section, planning sessions. So a lot of inputs have been taken over this period. So what we are thinking is to approach this problem of managing the spine care in Nepal into two different patterns. One is a macro level, which is at the national level, and that is what we are planning with the National Spine Health Program. And the micro would be much more manageable at a professional societies level, where we are trying to conduct an outreach clinic in Karnali. Then we have some implementation studies going before and after the intervention setup, which we'll be putting on Karnali, and looking at what outcome differences which we can achieve by putting on this philosophy of healthcare at micro level. And we are also planning to start masters in physiotherapy, particularly concerning spine care with universities, if in case it's feasible. So these are different things which we are planning and do different prongs. So the vision of the National Spine Health Program had been to ensure that everyone had access to the highest quality of spine care possible to the healthcare system in Nepal. This is very important for us to understand, because healthcare system is widely available in Nepal through the government setup as well as to the private-public partnership. And if in case, if the quality of the services which is provided to them is standardized, then of course everyone has an access to this. And the mission would be to provide a practical, evidence-informed and sustainable spine health model across communities. So what we are planning to do is to adopt GSI model of classification and the care models. And the philosophies, as my previous speakers has already said, right care at the right time by the right team in the right place. And why this motto is already been professed is that we all know acute problem is easy to tackle, but once the acute problem becomes chronic, particularly in the pain, then it becomes a pain for all, not only for the patient, but also for the system who manages that patient, because then the cure never comes in so fast. And henceforth, we need to train the people, particularly working as the primary contact for the majority of the public in Nepal, those are the community healthcare workers, into community spine health provider. So, and then keeping the term primary spine care provider reserved for that particular situation, where we will have a team of experts who are trained in primarily in spine care, but particularly from physiotherapist background. So if in case we can do that, then at the community level, when the village health worker sees a patient, they would have certain things in the mind to approach this patient according to a protocol. And then the subsequently non-surgical spine care provider and the surgical spine care provider, which the definitions my previous speakers have already said, can actually come along with it. Now, why we are classifying all these healthcare providers into these three terminologies is because we want to blur the margin between the different specialties. We are trained from neurosurgeon side, we are trained from orthopedic spine side, we are trained from physiotherapy side, there are chiropractors, there are occupational therapists. So there are a lot of people who are trained in managing certain portion of the spine ailments. We should not claim that we are trained in everything, but then we are trained in some portion of the spine care. But then patient requires a wholesome care. And that's why if we can blur the margin between the different specialties and then classify according to these three simple classification, it makes the life very easy to classify and to refer the patients also subsequently. And also when we use a single model of care, then it will be easy because the language we speak will be understood by each of us. If somebody says category 4, category 5, we know what we are talking amongst each other. But if in case somebody will say facet arthropathy, or there is some other problem like subluxation, then only few of us or in the whole team of healthcare provider who are actually the primary care provider in villages may not understand these terminologies. So that's why it's very, very important for us to use simple terminologies at our places so that people can understand what language we are talking about. And henceforth, we strive to create a proper referral system by training the primary caregivers so that we have the largest approach, largest reach to the public, as well as enrich our current spine fellowship program. Even a spine fellowship program, which are surgically oriented, they have very little place for conservative care and the rehabilitation program. So we need to put some period of exposure to these people also, and also train our allied specialties so that the allied specialists also understand the surgical specialists as to what we are talking when we're taking about care of these patients, and also help in developing a national registry for spine problems, generate database and improve research, and use evidence-based practice in spine care. Now, we have a very well-defined public health system in Nepal, both working at the community and the regional level. What we want to do is train the community health worker into the approach laid down by the Global Spine Care Initiative, so that we can actually get to the grassroots level and can create a good referral system. Now, primary health care is the key to the universal health coverage. This was the term which was coined in 2019 by World Health Day celebration in matter of providing a universal health coverage. And henceforth, PSC always plays a role here. We have a doctors there, we have a good, well-trained health staff. They can also be trained in these protocols. So Global Spine Care Initiative, which comes very handy to us because it's already an evidence-based program laid down. What we are planning to do is we are trying to adopt this program into the Nepalese scenario, because nothing can be copycat in our situation. Our situation is very unique, and henceforth we need to draft in a very modified manner. And then once we actually adapt it, then we can actually go for a review and then refer. Now, Nepal is very different because of its unique geography, unique psychosocial needs, unique working environment, and even unique healthcare delivery system. As Dr. Bimal just said, that our pharmacies sometimes work, not sometimes, but most often times works as a primary care provider in the urban as well as in the rural setup, which we haven't ever considered. So that's why we need to consider those elements also. So over-the-counter drugs are very fairly easily available in Nepal, and that's what the people actually keep on taking these medicines and stay at home rather than taking other preventive measures to avoid the problems coming up in future. So what we are trying to do is to make 3 co-working groups, including all stakeholders, and then try to make a plan, a draft, so that the spine health program, what we are trying to do should be taking all the elements into consideration, modify the GSI model. If you see the GSI model, it is still very complicated. The sub-classifications, the categories they discuss, it is not very easily doable in the community setup. So we need to cut down most of it, and Geoff and Andre have actually come up with a very simplified version. So those 10 questions which you just saw was the recent work which has come as a modification of GSI. So we are still planning on that. So these are many things to draft. There are many things to plan now. And as the planning and drafting goes on, simultaneously, we can have a committee which can actually make a plan to how to train in this GSI model, because all those play card system, all those diagram system which Geoff has made in his presentation needs to be taught in a very primary language, need to be Nepali Karan Bhansani. So we have to convert it into Nepali so that it becomes a lot more easy for people to assimilate it into their practice. And at the same time, we need another arm to see whether the implementation of these things are going in a correct manner or not. So the execution and implementation part is something else we need to consider. So these 3 working groups can actually help us in taking the things forward. At the micro level, just a brief talk. So an outreach clinic in Karnali is being planned, and Karnali Academy of Health Sciences is helping a lot in this. So recently, Geoff and Andre had been in Karnali together with Dr. Neelam, and they have done a field survey and have come up with a very good plan, as well as some MOUs, I think, is supposed to be signed. So then in case that happens, then our first outreach clinic can be started as soon as possible. Now, this outreach clinic will also serve as a training center for the physiotherapists, as well as for other volunteers who want to go to the micro level, to the villages, and see how this program can be run. And then to study the effects of implementation of this project, we have already submitted a collaborative project titled Evaluating the Readiness and Feasibility to Implement an Evidence-Based Model of Spine Care in Rural Municipality and a Tertiary Facility in an Urban Setting in Nepal, a Global Spine Care Initiative Implementation Project, details of which will also be told by Dr. Andrew in his presentation. So there are a lot of things which we are actually planning, and we are in our phases to do it. But then the big question is how to make the program sustainable. We are still in a very, very nascent form. We are still in the planning stage. And that's why there are a lot of things which are still unclear. And that's why we need the ownership of Government of Nepal and Ministry of Health and Population to take the leadership and see this particular program go through. We have already understood that is required, and we have already comprehend that it is doable. It is nothing which is a very Herculean task. Only thing is some amount of coordination and leadership is required to pull the things together. And then there are a lot of professional organizations which I can see they're very much willing to give their time and energy into this project. So things are everything there. So we have a fire, we have a things to burn, we even have a good environment where the fire can take place. So there's nothing else which is required, only a good leadership and an ownership. If in case goes along, then this particular thing can be kindled a long way ahead. And then of course in the education sector, we are talking with the universities, if in case we can put it in a small section into the undergraduate programs, as well as in the postgraduate level, when we start to train some spine specialists. And then similarly, training programs are required for primary spine care providers or community health spine providers to start with. And also the trainer program sessions are very much required to go into it. And feedback cycle is ultimately required so as to drive this program into right directions by giving feedback at the right time. So with this, I would like to conclude my presentation. We had a lot of discussion, which actually occurs at 10 o'clock in the night in Nepal, just to keep track with the international partners. But then even though we were sleeping, most of us are sleeping during the talk, it seems. But then our brains are still active and the fire is kindling in our heart. We want this program to take its shape as soon as possible so that we can all become a force to reckon with. Thank you for your patience listening, and I will be open for questioning.
Thank you very much, Professor Amit. Talking about the timeline up to till now, where we have come for the National Spine Health Program. And the next presenter is Dr. Andre Boucher. He is also from World Spine Care and expert in research implementation. We'll be talking about measuring the effectiveness of the program. Dr. Andre Boucher.
Good afternoon. Thank you very much for the invitation. It's really my pleasure to be here today and be able to discuss with you how we could potentially implement the model of spine care in Nepal and evaluate throughout the micro and macro level the success of the program. So if I could have my slides, that would be wonderful. We had the privilege and opportunity to visit Karnali Jumla, and more specifically the municipality of Kuchikar in the recent week. And this was extremely important for us to understand the context by which patients are seen, managed at the local level. We also are fortunate to have collaborations with our colleagues at Kathmandu Medical College. And so what I will be discussing today is essentially thinking of the model of spine care, where we have discussed the classification system already, the flashcards, which are basically guidance for clinicians to make informed decisions about where and how best to manage the patient at the different classification that was mentioned. Think now of this as a program, which is quite complex, has many, many fields, many different people that are involved at different times. And we need to now consider how we're going to implement this at the micro level and at the macro level. And how do we evaluate the success? So without further ado, and I would like to acknowledge all the collaborators on this effort. And this is part of the work that we have submitted to the University Grant Commission and hoping to be successful. This is a four-step process. The first one has been discussed already, the creation of the model of spine care. And we're now going to go into the specific customization and pre-implementation and talk about the feasibility to implement this model of spine care in Nepal. And lastly, at the fourth phase, learn from all these different studies to be able then to have a large-scale sustainability impact study in Nepal. The model of spine care, as we now understand it, and is being slightly modified, tailored to the need and the system that is in place in Nepal will then be implemented as follows. It requires to have effective implementation strategies. The literature is very rich in understanding what seems to work at what level. By level, I mean targeting the decision makers, the policy makers. We require extremely strong engagement at all levels for this to be sustained over time. We require strong engagement of care providers as well, at the community level, the secondary and tertiary care level. Patients themselves, who are going to be managed and will have to learn about self-management. All of this therefore requires to be contextualized. The Medical Research Council provides this framework for us to understand a little more how we can go about to implement. Right now, we're in the red box. What we're thinking about is looking, of course, at the context. We're thinking of developing program theory so that we understand when we do something at one level of the healthcare system, how does it impact the outcomes? We need to think about uncertainties, the challenges of doing so, and refine the different strategies we'll be talking about in a few minutes, and think about the economic impact. This is an iterative process that we then would like to think about the feasibility as phase 3 of implementing the model spine care in Nepal in 2 regions, a rural community and an urban setting, and then measure the impact. So what we first need to think about in terms of purpose is to explore the readiness of the model spine care to be implemented within these 2 regions I just mentioned. We need to confirm the magnitude of the problem. How big is this an issue? How does it impact the community and people that have spine pain? What is the perceived value of the stakeholders, meaning decision makers, the clinicians themselves, the population, the residents in the municipalities, and whether there are challenges that we need to think about and improve on the solutions that we would like to use to implement the model spine care. The 2 areas is the large urban setting here in Kathmandu Medical College, as well as the area that the rural community we were able to visit for a week in Kuchikar. Why? Because it's one of the far remote regions of Nepal. It is difficult to access. It is currently underserved and absolutely beautiful to visit. The design is called a mixed method approach, where we measure both quantitative and qualitatively using a participatory approach. Participatory approach is absolutely essential for models of care like this to be adopted. This is where people collaborate from all the different levels I spoke about for this to be sustainable over time. We need to think of this as a stepwise approach. We need to learn, prepare, understand the context, plan, and design suitable implementation strategies that we will test in future studies, which is the phase 4 talked about. We would like to include adults with spine concerns and pain, the caregivers at the different levels we talked about in those 2 settings, including municipality leaders and decision makers and policymakers throughout. The goal is to customize, prepare the implementation, and therefore, and I'll repeat this several times, stakeholder engagement. And we need strategy to do so. We collect information from the Community Health Survey, which is an orally administered survey going door to door in the community and asking, does any one of the adults here has back pain or neck pain? And how do they manage their problem? How important is this? And how disabling is this? We'll have chart reviews in the facilities, healthcare facilities, to understand what is currently being done for these patients. How are they managed? And interviews, understand the perspective of the different stakeholders I mentioned about the model of care and how they see the context and the need to adapt this. The data will be analyzed and further adapt, both for the classification system, the flashcard that Jeff mentioned, as well as the implementation strategies. We need to also think of this as a multidimensional approach to evaluation. The program is on the far left, model of spine care. The implementation strategies have to target all the levels I've mentioned again. There, as I said, a number of systematic reviews and meta-analysis about the effectiveness of different strategies, but are they perceived to be useful, applicable in the different contexts where we're going to implement this? Outcomes of implementation are those where we're purposely and intending certain actions to be able to integrate the model of care into different contexts. Service outcome is what care providers do on a day-to-day basis. Clinical outcomes would be those of pain, function, disability, and quality of life we would measure at baseline as well as after the implementation of the model of spine care. This leads us to the third phase, which includes then the likelihood of being able to integrate the model of spine care in those two communities at all levels, and then measure the potential impact it has on the patients themselves and on the community. So let's imagine we have a patient, comes in with back pain. He's being seen by perhaps a community health worker. It could be a provider, clinician with good training, could then decide whether this patients need to be sent for urgent care, or we move on to further assessment. Trained clinician can provide the full history taking, appropriate physical examination, and recommended care for this patient. We therefore can measure at each of those steps what is being done, how is it being done, and what is the impact of this doing. And ultimately, patient would be either discharged, they're doing better, and they're self-managing, or they need further evaluation and treatment because the pain is ongoing. Or last, they need to be seen by a healthcare specialist because the problem is not improving or getting worse. The plan is therefore to administer a number of different tools, instruments, validated questionnaires, and again, run interviews and see how people have changed as a result of the implementation of the model of care. And we'll do further adaptation if needed. These are measured at the decision maker level. We have measures for the clinicians themselves, for the patients, and for the community educational program that we're intending to implement as well. And so this is done pre and post implementation, and essentially over a 2.5 year period, we would be ready then to be thinking about the next phase. This means that we will have learned about the community needs, the community interest, and the perceived usefulness from those two very different regions, the rural community and the urban community. Therefore, we're left with, hopefully, a culturally acceptable model of spine care that is seen to be very useful, that it fits with a gap currently that is identified as a need. The next phase would therefore be to then think nationwide of scaling up and implementing the model of care in the different provinces. Reaching the four main aims of the model of care would be to improve patient health, improve the experience of patients throughout, the experience of clinicians, and finally, to be able to improve on the way in the access and the cost reduction and efficacy of the healthcare system as a whole. We think of randomized controlled trial as being the gold standard for treatments. We compare on the left-hand side, one treatment versus another. Does this work better? Is it cheaper? What we're talking about here is a very complex model of spine care. It's a program. And therefore, implementation research is rather on the right side and more in the natural environment. What we need to do then is think of something that's quite pragmatic as a design, that is flexible and dynamic to the healthcare system, that respects the local context issues and is meaningful to the end users. There are a number of different types of research designs we can use then to study whether this is indeed effective, cost effective, and actually made a difference to people. So very briefly, using this pyramid, we can think of measuring impact at the practitioner level and the patient level and the community level. Was there, for instance, appropriate use of advanced imaging? Have clinicians systematically used patient report outcome measures and patient report expectation? Have patients self-manage appropriately? Was the model of care used with fidelity? Have value-based care? The access is improved, the resources are used in terms of cost and people as effectively as it can, and there's benefit and efficiency and sustainability. Over time, this pyramid will reverse, and the system level measurement will become more important as data can be collected systematically throughout the system. Together with stakeholders, the decision makers, the policy makers, the clinician, the end users, we need to think about the important things we need to measure to determine whether this is successful or not. There's a continuous improvement process. I mentioned it needs to be pragmatic. We need to have a quality assurance program. We need to have systematic data collection. We need to be able to determine what are the key indicators that are going to say, yes, this is working. We're happy with the results. And the engagement of participants, and lastly, the uptake of integration. I would really to acknowledge the numerous people that are working on this program, the collaboration we've received and the welcoming, the funders as well, and hopefully the University Grant Commission, we're hoping to receive good news from very soon. Thank you very much.
Thank you, Andre. That was a very good summary of what all implementation projects we are thinking about. And next in line, we have again Geoff coming to the stage. We invite him to talk on WSC experience and outcomes.
So for 10 years, I was I still kind of guess I am the clinical director of World Spine Care. So my role was helping to set up programs different from the one we're working on here in Nepal, but different clinical programs in different countries. So we started in Botswana, where I lived for 2 years with my family to set up our flagship clinic. And then we moved on to other countries. You guys getting tired of that picture? What I want to talk about is global or World Spine Care. So we've heard over and over again about the burden of spinal disorders. Don't have to reiterate that, but our organization, World Spine Care, is the only organization that's really tackling this health crisis in an interprofessional, evidence-based, and sustainable way. The mission of World Spine Care is improving lives of people in underserved communities through sustainable, integrated, evidence-based spine care. We are registered as a charitable organization in Europe, Canada, and the United States. And we're endorsed through the World Health Organization through the Global Alliance in Musculoskeletal Health. The one presentation we missed by Deb Kapansky-Giles has a whole list of how World Spine Care has been endorsed and accepted by the World Health Organization. So I'll just leave it at that. So eventually we had 4 programs going, in 4 countries. We attempted to set up programs in other countries like Ethiopia and Tanzania, but a lot of elements have to come together for something to actually work. As Andre is talking about stakeholders, we need the right stakeholders, we need the right funding. And it doesn't always work in every country. But we did manage to set up 4 programs and have 7 clinics running in Mocha, Dominican Republic, Accra in Ghana, Shishong, Mahalape, and Habaroni in Botswana, and Navi Mumbai in India. So I'm going to go through each of those. So Shishong, Botswana was the first project we set up. And we actually set up a physical clinic in a rural village, very much about as rural as where we just were. And the idea was to set up a clinic where we were actually providing really high-level spine care. So we had the primary spine providers, the spine specialists, that was chiropractors and physiotherapists with advanced training in spine, who were running the clinic, because we wanted to see if we went out there and we did that, how do we need to modify what we do? What can we learn from these communities so that we can be more effective at delivering care in those communities? And can we be effective? So we had a whole data collection process where every patient, we would enter data in a spreadsheet, and I'm going to show you some of that data afterwards. So this was what we were trying to do, and doing that in multiple clinics. So that was a primary care setting. 40 kilometers away was Mahalape District Hospital, and this is where we actually physically live, not in the hospital, but in Mahalape. So this was a secondary care center. And we had a primary contact spine care clinic inside the secondary center. So again, chiropractors and physiotherapists with advanced training were running this clinic. Patients would often go through the orthopedic surgeons or the medical doctors and be referred to us. Or after a while, once everybody got confident in what we were doing, they just started sending patients straight into us to, again, take away that burden from the surgeons and the medical doctors who are dealing with all kinds of back pain, neck pain, headaches, and so on. So this was a primary care clinic in a secondary care setting. And then we eventually, and I don't have a slide of it, but we eventually moved into the main referral hospital in Gaborone in Botswana and set up, again, a primary care center inside now the tertiary care hospital. And lots of patients were referred through the surgeons, spine surgeon. Actually, at the time, they did not have any spine surgeons. So through our organization, we set up a fellowship for one of the orthopedic surgeons to train in spine in Turkey, and he then returned and sort of became part of that spine care team. Then we went down to Mocha, Dominican Republic, and this we had set up again, primary contact clinic run by chiropractors and physios with advanced training inside a rehabilitation institute associated with the Mocha District Hospital. And this Dr. Haldeman, who you just listened to in the presentation, and Dr. Tavares, who is part of our team in the core working group for World Spine Care and the National Nepal National Spine Care Program, and then Dr. Eberspecker, who's also been involved in helping with some of the work with this program. In Accra, Ghana, the clinic it's actually a medical doctor who's also a chiropractor, so a lot of training, very good with spine, and she was running a primary contact clinic inside the outpatient department in the Ridge Hospital. And then at the Mahatma Gandhi Mission University of Health Sciences in Navi Mumbai, it's a large physiotherapy program. And the physiotherapy clinic is inside the hospital. And so part of the physiotherapy department, there's a World Spine Care division. And so the physiotherapists will go through and do spine specialty training within that. So now we sort of have a generation of physiotherapists graduating from this program who have more advanced knowledge in spinal disorders. And have any of the physiotherapists here been to the Mahatma Gandhi Mission University? Okay. And that program is still going on, and that is one of the other sites we're looking at implementation. So from these clinics, I'm going to show you the outcome measures that we use, because we want to know where we're actually getting patients better. The first, the one is the Wong-Baker Faces, and basically a pain rating scale. I'm sure the physios are familiar with the Wong-Baker Faces, but we had to modify it because some of the terminology and some of the stuff we were looking for outcome measures that could be implemented in low literacy populations. And that becomes difficult. You've seen all the outcome measures that you've used. A lot of them are either not relevant in a rural community because they're set for people in cities. They're talking about getting off and on buses and going up and down stairs. When you're in a community where there are no stairs or the people don't use transportation. So we had to do a lot of modifications. And one of the other ones, so activities of daily living was very difficult, but we did strip it down to the types of activities that everybody does all around the world, all the time. You get up and out of bed, you walk, you sit. So it was wrapped around that. But the other more important one was the patient-specific functional scale. As a clinician, we walk in and we say, okay, what can't you do because of your pain? And the patient tells us when they come into the second treatment, we ask them, well, can you do that now? Or are you still having difficulty with that thing you couldn't do before? So the patient-specific functional scale is just an outcome measure that does that. What are the things that you can't do because of your pain? Rate them on a Likert scale. And every time they come in, they reevaluate how they're doing. Can you now do it more easily? Can you do it completely? Are you still having difficulty? And then the last was a brief depression screen. So the data that I'm going to show you is using these outcome measures. Having the same problem Niba was having with the, okay, how do I go back? There we go. Okay, so just in terms of demographics, these are fairly consistent with what we see worldwide. Usually more females. Mean age is sort of 40s and early 50s. The percent serious red flag pathology, you'll see 13, 9, 12. That's pretty consistent. That doesn't mean those are surgical cases, but those are red flag pathologies that needed to be referred to secondary and tertiary care. the percent of patients that presented with non-specific pain was quite high. Most of the patients walking in. This is what we're saying. 90% of the patients that come into that have spinal pain are presenting with non-specific pain that can be managed at a primary or a non-surgical level. You'll also see that the percent serious red flag pathology and non-specific pain, they don't always add up to 100 because sometimes it's a specific pathology that isn't a red flag, like a radiculopathy is a specific pathology, but it's not a red flag referral. And then the percent of the patients coming in where their first complaint was low back pain is also quite high. And then the number that are coming in that their primary complaint was spinal pain, not just low back pain, but any spinal pain was quite high. Now we were World Spine Care, so maybe that was why we had a little bit higher numbers in spinal disorders. Also, patients, the vast majority were chronic pain. That's over 3 months. And also, the vast majority of that pain was interfering in something in their life. Okay. So then we treated them and we looked at the average number of treatments to therapeutic resolution, and we were around 5, 6, 7. Okay, and sometimes that therapeutic resolution was this person is going to have to be on maintenance care because they need continuous care on a regular basis to maintain their quality of life. We can't do any better. Sometimes that resolution was we got to refer you to surgery. So it's just average number of treatments beyond the initial visit to some sort of a decision on what to do long term. So the percent that had clinically significant reduction in pain, and through the research, you'll see clinically significant, maybe anything between 20% and 30%. We thought we were going to use 30%. And so the vast majority of patients had a clinically significant reduction in pain, even more significant improvement, increase in function, and then percent with clinically significant increase in activities of daily living. So remember, reduction in pain was the Wong-Baker faces, increase in function was the pain-specific functional scale, clinically significant was the ADL questionnaire, and then the reduction in that brief depression screen. Now, these numbers are all numbers we collected with patients that we got a final outcome from, but you could see about 40% of our patients would just self-discharge. And then we'd have to chase them down and try to get some answers. And of those patients that we got answers from, you can see the 61% in brackets had clinically significant improvements, 54% clinically significant, 50% clinically significant, which means that all of these numbers that you see above are based on the people that we didn't chase down. But when we finally chased them down, these numbers even got better. So what we got out of this is that if we have really well-trained spine specialists out in a primary care setting, whether that primary contact setting, let's say, whether that's in a village or rural community, a secondary care facility, or a tertiary care facility, those primary spine care specialists, those non-surgical specialists who have advanced training in spine, can have a really great impact on the outcome of patients. And if they're really good with their triage and their decision-making and they're monitoring the progress of the patients, they're going to make very appropriate referrals of when they need to go to a surgical consult. So the surgeons don't end up seeing all kinds of back pain patients that they are just going to have to shuffle back down to the primary contact. So that's what came out of our clinics. Thanks again.
Thank you, Geoff, for a very lucid presentation on your experiences over these different countries. So we see this particular initiative had been there in many countries, and even in Nepal, the thirst is giving but much more deeper. Now we will have Professor Paulo Pereira. He will be speaking all the way from Portugal, and he is basically presently the General Secretary of the Spine 20 initiative. Spine 20, it's a group of G20 countries who are into this sort of program. And he will be talking on Spine 20 initiative. So can we have Professor Paulo?
Thank you. Can you hear me?
Yeah, you are audible, Paulo.
Okay, perfect. So let me share my screen. Okay, I believe you can see it now, right?
Very well.
Perfect. So, my name is Paulo Pereira. I'm a neurosurgeon fully dedicated to spine from Porto, Portugal, and professor of the Faculty of Medicine of the University of Porto. But I'm presenting here on behalf of the Executive Committee of Spine 20, and we'd like to start thanking the organizing committee and particularly Professor Hamid Tapa for the kind invitation and the opportunity to present the Spine 20 initiative in this forum. So what is Spine 20? So Spine 20 is an advocacy group involving international societies who strive to optimize spine care on a global level by creating recommendations on health policies at the G20 summit. So our mission is to optimize treatment in the global community to ensure patients have access to the best spine care possible in their respective regions, envisaging a world where appropriate spine care helps minimizing global disability and dramatically improve the lives of those suffering from spine problems so their families and communities can thrive. So how can Spine 20 help governments to alleviate the burden of spine disease and disability? Serving as a research in spine-related healthcare and prevention, advocating for the prevention of spinal disorders, advancing spine research, stimulating innovation, and facilitating access to spine care and treatment to improve function and decrease disability of these patients. And how can we influence change? So by creating policy recommendation, establishing a legitimate connection to the G20 group, and leveraging global connections. And who are we? There are 4 founding societies, which are the German Spine Society, Eurospine, the North American Spine Society, and the Saudi Spine Society, and 10 other societies join it as partner societies and are members of the Spine 20 Advisory Board. And we welcome all societies or journals interested in spine-related disorders to participate, discuss, review, and endorse our recommendation. This is the organization of Spine 20. The executive committee is made up of representatives of the 4 founding societies and of the host societies of past and future Spine 20 G20 summits. The chair of each annual meeting is responsible for the communication with the G20 Sherpas and the official G20 groups, reports to the Spine 20 Steering Committee, and coordinates the annual meeting task forces. The preliminary plans of Spine 20 were set in a meeting with representatives of the 4 founding societies during 2019 Eurospine annual meeting in Helsinki, and the follow-up workshop was organized 3 months later in Riyadh. Then COVID-19 pandemic arose, but the founding and the partner societies kept working together to organize the first annual meeting to be held in Riyadh in November 2019. This is how Spine 20 works. So there was a steering committee for Spine 20 meeting in Riyadh. Then a scientific task force designed the program for the meeting. The publication and recommendation committee task force created recommendations that were published in the European Spine Journal. And then the same circle for Rome with the steering committee, the scientific task force creating the program, the publication and recommendation task force creating the recommendations that have just been accepted last week to publication in European Spine Journal again. And we keep working on that for next meeting we're gonna be in Bali. So for each annual meeting, spine-related domains are selected and symposia are planned according to these domains. Spine 20 annual meetings are summits with the participation of individuals and organizations. So the challenge for Spine 2020 in Riyadh was the execution of the defined plans. The theme of the meeting was ensuring access to quality spine care to prevent disability throughout the world. And 8 symposia were organized. These were the team members for Riyadh. These are the 8 symposium, and 2 sets or recommendations were created, a full pack of recommendation and an executive summary that were sent to the G20 representatives present in Riyadh through the Sherpas. The challenge of Spine 2021 in Rome was to prove the continuity of our plans. So the topic, the theme was care for people's health and prosperity. 6 symposia were created. Again, these are the team members, the 6 symposium, the 2 packs of recommendations. And these were the countries from which we had individual participations, and we see the partners and the endorsing societies and 2 endorsing journals that were Global Spine Journal and European Spine Journal. So next meeting will be in Bali in August this year. After learning from previous meetings, we made our organizational process more structured and efficient, with a well-defined timeline for the scientific and the publication and recommendation task forces. We are now finalizing the program, so we are in the middle of this process. And as usual, the theme was defined by the local host, but to strengthen the methodology, we implanted the Delphi method to select the domains for the symposium that were chosen by at least 75% consensus between the 21 experts who participated in this session after 8 rounds. Lastly, the subdomain of each symposium was decided by the co-chairs. Hence, 6 domains were selected during the Delphi session, and a 7th domain was decided by the host country. In 2022, we also decided to include the education as a permanent domain, and that the corresponding session will be organized by the Education Committee. According to the available places, it was decided that each founding society had the right to nominate 2 co-chairs, and the partner societies and the next host countries 1 co-chair each. You can see on the right table the chairpersons nominated by the different societies together with their symposium preferences. The theme for Bali will be Spine Care, Work Together to Recover Stronger. And you can see here the domains, subdomains, titles for each symposium together with their chairpersons. We are delighted that we'll have the privilege of having Professor Amit Thapa as speaker and panelist on the Access to Care Symposium. So we believe that Spine 20 represents a disruptive approach, aiming for global engagement, reaching out to stakeholders, and delivering recommendation to G20 concerning spine care that can promote excellence in developing countries and capacity building in the underserving communities. Thank you very much for your attention.
Thank you, Professor Paulo. Next, we'd like to welcome Dr. Rudra Marasani. He is going to talk on next steps for the National Spine Health Program. Dr. Marasani, he has worked in Government of Nepal in various capacities. Yeah, Dr. Marasani.
Thank you very much. respected chair, co-chair, and all the delegates. Thank you very much for inviting me in this prestigious forum. Today, I'm talking on behalf of Director of Management Division, not as an orthopedic surgeon, not as a spine surgeon. Now I'm working in the public health sector under the Ministry of Health and Population as a director in the Department of Health Services. So I have very short presentation, and just I will find out the way how we can initiate this national spine program in our national program. I just want to share that only. Sorry. Now, why the spine health program is not a priority program of government of Nepal? I just want to highlight our priority programs are communicable disease. Yeah. Sorry. I just want to. Okay. Spine health and rehabilitation is a neglected part of the hospitals and the government as well, because we are not working a lot in these fields. And there is no comprehensive spinal injury management center in Nepal, except few centers in the private and community level. Government doesn't have comprehensive center, and even the private hospitals, they are very beautiful. We have very beautiful private hospitals, but they have not comprehensive spinal care rehabilitation center. The reason is this may be it's a neglected part. I want to say this is a neglected part. So even there is no even single center, spine center in the government also. We have lots of orthopedic hospitals. We have lots of central, regional, and provincial hospitals, but no specific dedicated spine centers. So in the other priority programs, government of Nepal is spending lots of money in the other programs like infectious diseases, communicable diseases, tuberculosis, HIV/AIDS, Kala Azar prevention, even polio, and they have spent lots in the maternal and child health, reducing the maternal mortality, neonatal mortality, community-based IMCA program, and even the donor agencies. We talk about the World Health, WHO, even USAID, and all the donors, they are working only in these programs. They are investing in HIV/AIDS, communicable diseases, wash and hygiene, all those things, but they are not investing in our spine care and this burden. So we have to create a awareness why this is important and why this has to be a national program. That is the main challenges for us. And we are working on achieving the sustainable development goals. And there are, all of us know that there are 17 components. None of the components includes this spine and other rehabilitation service. That is also very, I can say this, again, this has been also neglected from the national as well as international level. This is not a priority program. Okay, I'm not talking about this in details. And we have lots of work has to be done in the spine health and rehabilitation services, palliative care, occupational health, and the comprehensive trauma services. Even we have trauma centers, we have beautiful private hospitals, well-equipped hospitals, but trauma care, there is no comprehensive trauma care. We are doing lots of advanced surgeries, but the service is not comprehensive, and the poor peoples are not getting this very easily. So we are doing spine, very technical and sophisticated spine surgery. And you see, Nepal Orthopedic Association, there is a lot of colleagues. I'm also orthopedic surgeon, and a lot of colleagues are operating in the spine. There are Association of Spine Surgeons, there are a lot of spine surgeons, and Neurosurgical Society, which we are talking right now. There's a lot of people who are working in the spine services, but we have not worked enough in the rehabilitation services, and we have not given this is a priority. So this initiative, Dr. Amit and the National Society of Spine Surgeons, you have, I would like to congratulate you. You have started this initiative, which is a neglected part and not a priority program in our national health program. And this is the only one rehabilitation center, I say comprehensive rehabilitation center in the Nepal. That is the Spinal Injury Rehabilitation Center, Saga. There is not, still we need to have at least 5 to 7 comprehensive spinal rehabilitation center, at least one in one province, I say. But we didn't have, even in the single center, not in the government level. Okay, spine surgery, doing spine surgery is not a spine care, because spine surgery is a very small part of spine care, I say. Doing the bad surgery is rather than not doing the surgery. Doing bad spine surgery is better than not doing the surgery. See, this patient is suffering. How much this patient suffered? So this is this patient is having cervical myelopathy of JOA 70, at least a complete cervical myelopathy, JOA grade 15 up to. And see the status. She has been operated, but how surgery? What type of surgery they did? This type of surgery, doing the surgery is bad rather than not doing it. So, and what we are doing, and we have started little bit in spine care. Government has initiated the social security scheme for the spinal injured patients. We have started. We are giving 100,000 Nepalese rupees for the treatment as a social security program. Once the patient got injured, we are providing 100,000 rupees for the treatment as well as rehabilitation services. So to include all the publics, all the poor people can achieve, can get the free treatment. That is the motto of this 100,000 rupees, Nepalese rupees, for the surgery as well as rehabilitation purpose. But in this program, most of the private hospitals are not listed. This is very bad news, I say. Most of the government hospitals are listed and community hospitals are listed, but most of the private hospitals are not listed in this package. So I would like to request all the private hospitals, please use this initiative and try to give the service by using the government fund and treat the patient freely, so that we can treat the patient freely. And we have also initiated at least 5,000 rupees per month for the spinal injured patients as a allowance. Spinal injured patients get 5,000 per month as a allowance in our national health, in our health program. So these are the social security schemes which we have initiated for the spinal injured patients. And the spinal rehabilitation and the palliative care has been included in the national policy of the government in fiscal year 79-80. This year, because I'm working in the Department of Health Services, and I'm proudly say, I'm talking about this rehabilitation services should be a priority program. And I am raising this issue many times in ministry as well as in Department of Health Services, so that we have able to include this rehabilitation and palliative care service should be the priority program of government. And this has been included in the coming fiscal year program. And Niti Tatha Karyakram, in Nepali we used to say this Niti Tatha Karyakram, which has to be endorsed from the parliament, and this has been included in this year's Niti Tatha Karyakram, and so that it becomes a priority program from subsequent years and subsequent months. What next? We have make a concept of at least one comprehensive trauma center in one province, which includes the spinal services also. And this has been approved by the government, and feasibility study and detailed project reports has been works has been done in this concept. This one trauma center, comprehensive trauma centers, which includes the services of spine as well as other type of trauma. This has been approved by the government last year, and the feasibility study and DPR is being done. And we are also making a comprehensive management of spinal injured patients program as a health package. In this, the annual budget and work plan, AWPB, we say annual budget and work plan. In the coming years, annual budget and work plan, we have included comprehensive management of spinal injured patients, a training program for the health worker. And this includes the training of the physiotherapist, training of the nurses, and the training of the medical officers who are working in the remote areas. And we are also working on the rehabilitation and palliative care centers. At least one center should be in one province. This is under discussion, but these have not been finalized. And this is under, we are discussing, we need to have at least one rehabilitation centers in at least one provinces, which center would work exclusively on the rehabilitation of the spinal injured, as well as other stroke patients, spinal injured. So there are lots of patients who are not getting the rehabilitation services. So, and from the coming year, we have also planned for the national treatment protocol for the spinal pathology. All the spinal pathologies, we wanted to prepare a national protocol in the Nepalese language, simple language. This work is initiated by the Curative Service Division, and that training will be conducted by the National Health Training Center, NSTC. So I am very happy you have initiated the National Spine Health Program. So let's work together. Let's put this in our national program. Let's make it a priority program, and let's work together. That's what I want to say. And from the next year, I'm hopeful that we will create the protocol. It's Nepalese language, very simple language, to be understood by the medical officers, paramedics, and nurses and physiotherapists who are working in the rural areas. Then it has been gradually, this will become a priority program. That's what I'm thinking, and I'm talking with our secretaries and our director general and other planning peoples in the ministry. Let's see how much we can do, but we have to be very positive, and we have to work on the spinal pathology, treatment of spinal injuries, spinal pathologies, and mostly the neglected part. I always say the neglected part is the rehabilitation services. So thank you very much. Thanks for inviting me. Thank you.
Thank you, Dr. Rudra. We can appreciate the initiative that you have taken, being a spine surgeon. And obviously, you must have worked hard so much to include this rehabilitative service in our national health program. Now we come to the end of the session. So this is question and answer session. Professor Amit and Professor Scott will take over now.
Thank you, all the speakers. Zonet, can we have all the panelists on the screen, please? Yeah. So the session is now open for any queries, and you must have listened to the talks. So this deliberations have been made from personal viewpoint and a lot of deliberation amongst their own members and societies. So if somebody has any query, please ask, and then we will try to sort it out, and maybe we can have a lot of feedbacks from you all so as how to run this program much better and take ahead.
I'd like to just make one little comment. I'm extraordinarily impressed with this program. And a couple of the papers really brought up stuff we have to think about. Dr. Pandey basically illustrated that the problems we're facing in the high-income countries, namely just marked number of treatments with claims of success, is inherent in the police system as well. The second is the report by Dr. Pereira. This Spine 20 program is probably one of the most important programs out here this year, in the last couple of years. And World Spine Care is proud to be part of that. If Dr. Kapansky-Giles had managed to get her program together, she would have talked about the World Health Organization international guidelines on back pain, which is currently being developed, as well as a number of other programs. And then finally, Dr. Marasini actually showing some changes is such a promise. This is not a Nepalese problem. This is a worldwide problem. And we're all trying to come together wherever we are in the world to try and help those people who are so far being neglected, and despite their disability and abnormal quality of life. That's the only point I wanted to make. I'm very pleased to be here.
Dr. Paulo, you want to say anything?
Thank you. Thank you very much. Yeah, I'd like to stress what Professor Heldman just said, that this is really a global problem. And when we are, it's very important to have this effort in underserved communities and poorer countries such as Nepal. But a lot of money is in developed countries. A lot of money is wasted inappropriate care in spine-related disorders. And this is why I really believe that it's very, very important that physicians and non-physicians and clinicians who treat these patients came together and group around the supranational initiative, so that we can tell the government and the people who are in charge, who have to take the decisions about the immensity of this problem. As Dr. Morosini just said, it's really astonishing that being the spine disorders, the ones who are contributing more globally to the disability, to the years lived with disability of the population, so little attention and concern is given by the governments to this problem. And I really think it's our mission to come to them and to deliver to make our voice heard among the appropriate institutions and to involve the stakeholders in this decision. Thank you very much for the invitation.
Yeah, Professor Pereira, I would I have a query for you. Suggestion maybe that this Spine 20 is Nepal included in this program, this Spine 20 initiative?
Professor, thank you for the question. The Spine 20 initiative, as I try to say, welcomes all the societies and all people interested in getting together. Professor Amit just submitted the application of the Nepalese Society to the advisory board, so to become a partner society. We'll be happy. I showed you that we had besides the 4 founding societies, we have at the moment 10 associate societies, and a lot of other pupils we as individuals. So it's a very inclusive initiative, and the most countries, the more societies we have, and journals and stakeholders we can have together, I think the strongest can be our mission. So this is really very important. So this is not intended to be like a kind of elite group or lobbying group or whatsoever. It will be as much stronger as a more wide representative we can have from all the world. Thank you for your question. That is really very important and welcome. Thank you.
Thank you.
So, well, I don't see any raise of hand here, but then definitely your comments, both Professor Scott and Professor Paulo had been very welcoming, and with Dr. Rudra's comment about the Government of Nepal initiative this year and the years to come is also welcoming. And we have known by now that definitely the low back ache problem, the back pain problem is the #1 reasons for the global disability scales. And that's why we need to take care of it. And the patient-centric program is the key point now. So we should come across all the professional societies and try to work in the benefit of the patient. So do we have any other comments? Dr. Andre, would you like to comment anything? Dr. Rudra, yeah.
One thing I just forgot to mention is the lack of coordination between the agencies and different societies working on the spine pathology. So we also there should be a good coordination. What I am feeling, there's a lot of associations like Spinal Surgeons Association, Neurosurgical Association. There is a association for spinal injury patients, and we're working independently. But we need to have a good coordination because all of us are working in the working for the benefit of patient and improving the quality service. So why we should not work together? That is the main issue which I wanted to say, but I forgot. Thank you very much. Let's work together. All the associations should work together. So that it becomes a priority program. Otherwise, if we are working differently, then nobody will notice. Because the issue is there's a lot of burden, there's a lot of disease burden, lots of disability, but the problem is awareness. People are not worried. People are not worried. To make it aware, we need to work together. We have to work together and we have a common voice. That's why I want to say. Thank you very much.
Very well said. Very well
I can
said.
add to that comment. I've lived long enough now. I can remember the days when neurosurgeons and orthopedic surgeons didn't talk to each other because they were competing. I can remember when neurologists, I happen to be a neurologist, and radiologists had big wars on who should read brain MRI scans. I can remember when chiropractors were not permitted to join spine societies. All of these things are broken down. It takes a lot of work, takes a lot of commitment by people, but there's no reason why we can't achieve a combined approach to help patients.
That's a history revisited, but then the step has been taken now, and I'm pleased to say that the Nepalese Society of Neurosurgeons, NESON, has invited literally all the professional organizations to this meeting, and we have been having these types of talks amongst each other. And it's very pleasing to know that almost all the professional societies, they have the similar concerns. But since our training is different and most of the professional organizations are being made to serve their members rather than their specialty, there's a difference. The professional organizations are made to serve their members. I'm not very sure whether they are made to serve their specialty, because if in case they are made to serve the specialty, then these questions may not ever come, because the specialty always revolves around the patient. And whenever there's a patient care being discussed, then everybody has to come in tandem, in sync, and think only about one thing: how to give the best comprehensive care from all the other different modalities which is possible. So the steps are being taken, and it seems that a lot of different people from individual level, from professional levels, are very interested to take a key part. What we now need is definitely a plan, at least from Government of Nepal, a Ministry of Health and Population, to take a leadership here and then channelize all our inputs and energies into this particular model of care, so that we can also address to this #1 global disability problem in a much organized and effective manner to our population. So with these words, I would like to thank all the participants, as well as the faculties from abroad, Professor Scott, Professor Paulo, and all other who had been there with us, Dr. Andre and Dr. Jeff, who had come all the way from Canada after a very long journey, and also having visited the innermost places of Nepal to let us know as to what would be the best way to solve this problem. And all of you, you are always invited again. On Sunday between 12 to 4 at Kathmandu Medical College, Sinamangal, we will have a TOT sort of training program on this GSI model, which will actually help us to understand this GSI model much more better. And of course, we can have another set of feedback session from you all once you go through this model again. So thank you very much, and hope to see you again in a much more better way, coming up with a much more structured program, and then cutting a ribbon saying that now we have actually started the program. Thank you very much.
Thank you.
With this, we've come to the end of our first session on Initiative for its National Spine Health Program. I would like to thank our eminent speakers and our moderators for gracing us with such a comprehensive discussion. Now I would like to announce that we will be taking a 30-minute short tea break, and we will all be assembled shortly again for our inauguration ceremony. Thank you. So we will be assembled here at 6:30, exactly at 6:30 for our inauguration ceremony. Thank you.